Bienvenidos, welcome, good afternoon, good evening, good morning. My name is Sandra Castelblanco. Welcome to our webinar on mass gathering events and health considerations organized by the Latin American and the Caribbean chapter of the World Association of Disaster and Emergency Medicine, WADEM. This presentation will provide a broad overview of key health considerations related to mass gathering events. We will specifically focus on the provision of in-event health services, the impact of mass gatherings events on community health services, and challenges in providing healthcare. I will now hand over to Dr. Dukiram, who will introduce our esteemed speaker, who happens to be a registered nurse, which makes me very proud being a nurse myself. Just to remember, there is captions available, so please make sure that if you need it, you use them to translate the webinar into your own language. Thank you very much, Dr. Dukiram.
Thank you, Sandra, for that introduction. Tonight or this morning, depending on which part of the world you hail from, Professor Ranse, I am proud to introduce on behalf of the LATAC chapter of WADEM, Associate Professor Dr. Jamie Ranse, who is recognized internationally for his work on strengthening health systems for disruptive events that are unplanned, such as disasters, public health emergencies, extreme weather, deliberate acts of harm, or planned, such as mass gatherings or major events. He has over 125 peer-reviewed publications in disaster and mass gathering health. Dr. Ranse has a background in emergency and remote area nursing and has held various clinical leadership and educational roles in the context of mass gatherings. We have indeed been planning this webinar for a very long time. It coincides with many events in this part and in many other parts of the world. And Professor Ranse, we thank you in advance for the wealth of knowledge that you are going to share. I hand over to you, sir.
Brilliant. Thank you very much for the kind introduction. And it's my pleasure to be here this morning in Australian time, talking to you about mass gathering events and health considerations. When we think of major events or mass gatherings, everybody's probably got an image in their mind of what we mean. So it could be something like this, a music festival. It may be a large sporting event such as this, a fun run. Or it may be something like this, which is from Australia, 2008 World Youth Day, where the Pope visited. And this is a race course with about 300,000 people inside a race course. So mass gatherings, by definition, vary in size. And because of their varying size and other characteristics, they place a burden on our health system. And they also challenge us in providing healthcare for people who are at those particular events. So my work is about how do we provide adequate health services for people at the events, whilst protecting our normal community resources like ambulance services and emergency departments, so that those services can maintain their normal operational capacity during a major event. Some people might start to define a mass gathering based on the number of people that are involved. I don't necessarily like to do this as a single and unique characteristic. Whilst it's something to be considered, we know now that there are many more factors which influence patient presentations. And a simple example would be, you could have a 20,000 person event, which might be a memorial type of an event, where that mood and motivation for people being there is to remember people for a particular reason. That 20,000 people type of an event is a very different event to a 20,000 person music festival, for example. So in terms of defining major events, I use the World Health Organization's definition, which has grown from their definition about a disaster, really. And that is about when a group of people come together for a particular purpose. There may be potential for a delayed health response, And because of that, we should put in place some particular strategies to buffer that particular impact. Now, when we think about patients presenting to our health services or at events, there's been well-established models now by Arbon for the last 25 years or so that is really focusing around 3 core characteristics. One being the biomedical makeup of the people at the event itself. That could be their age, gender, it could be whether it's a family type of event or not. The environment, whether it's hot, cold, whether it's an inside or outside event, whether it's on a flat surface or undulating ground, and psychosocial aspects relating predominantly to crowd mood and crowd motivation. As a result of understanding those things, we can implement in-event health services, and these are extremely common around the globe, ranging from people providing simple first aid measures at events, first responder type of responses, and these vary different across the globe and even within countries about what people might call these types of services. But these are normally lay persons who might have some additional first aid or first responder type training, but are not necessarily healthcare professionals. In events themselves, you may have healthcare professionals, doctors, nurses, paramedics, allied health, pharmacists, physios, and so forth. And then external to the event, you might have ambulance services needing to respond to the mass gathering, and of course, the hospitals themselves. So I'm going to start talking about the in-event health services to begin with. And these are just some images which people might resonate with in terms of varying sizes and complexities of in-event health service provision. And in talking about in-event health services, I'd like to draw on a couple of cases from Australia. And this is the first case. These are both coroner's cases, which I will talk about. And those that have been in my presentations before know that I talk about these ones quite often because they highlight some of the very simple things that we get wrong at major events. The first one here is a coroner's case in Queensland, Australia, at a community which is normally only populated by about 150 to 200 people, to which in this particular event, the population swells to about 3,000 to 4,000 to 5,000 people. It's a 2-day event. On the first day, people attend and they normally camp overnight. This young lady, Holly Winter Brown, died on the Sunday morning of this event. She went to bed in the early hours of Sunday, not feeling 100%, spoke to her father. Her father suggested that she just have a sleep and rest. She woke up in the morning, not feeling quite well. Her father said, well, have a bit more sleep. About an hour later, her father went to check on her and found her unresponsive. CPR was commenced soon after that by an emergency nurse who happened to be at the event itself. It took about 10 minutes for someone to call ambulance and emergency services. The ambulance and emergency services, because of the location of this event, were about an hour and a half away from responding. And there was no facilities to have to locate simple devices which might help, such as local defibrillators. So it was a complex situation, but highlighted from the coroner that there needs to be processes in place at events to communicate fast and effectively with emergency services, to have basic minimum standards for major events, like having a defibrillator on site, and having enough health and medical staff available for events. Now, even if all of those things lined up, it may not have changed the outcome for this person, Holly Winter Brown, but they are things which may have increased her chance of survival. Another coroner's case, which I'll briefly mention in Australia, related to 6 deaths of people at music festivals over a period of one summer at different music festivals. And the coroner explored these deaths, to which they determined some were avoidable. The in-event health providers at these events were minimal in terms of the number of human resources available for what they should expect to occur. such as patients becoming unconscious related to drug use. And in addition to that, lacked sufficient medical equipment to care for these patients, and that included both physical equipments and drugs as well. So from this, New South Wales, which is a state in Australia, determined that they would generate some minimum guidelines for music festivals and considered all music festivals to be high risk in terms of their impact on health services and the needs of people at those events. I don't necessarily subscribe that all music festivals are high risk. Again, there's multiple factors which are involved in patient presenting to our health services at events and externally. But as a result, these are just some Australian examples, and international, starting with the World Health Organization's guidelines around key considerations for mass gatherings, particularly from a public health perspective. And there should be a new version of this shortly. But these set out some really basic things to start thinking about from an event perspective. And here are some other Australian types of guidelines. Now, to note, most of our guidelines globally are often for events which we would call high risk, or would be for events which may be of international significance. So I think FIFA, Olympics, Commonwealth Games, and those types of events. But really, the events that probably cause the greatest impact on our health services are those ones in the middle, not the ones of international significance, not the ones which are a local fete or festival, but ones that sit in the middle, which often our health services don't even know are going to be on a particular weekend or evening until patients start presenting to the emergency department or calling for an ambulance to help. So I just, as a takeaway, I think about those grey, I call them grey type of events, the ones that sit in the middle, which aren't high risk, which aren't really low risk. They're kind of the medium risk ones, which events and health don't often talk about, may cause the biggest impact on your services. But despite having lots of guidelines and particular ones related specifically to music festival events, we still see the death of people at events. So perhaps these guidelines aren't necessarily effective because they're not necessarily evidence-based, and they're often based on the opinion of people who put them together, which is an admirable place to start, but we need to start generating some evidence about why these events occur and how we can protect people from abnormal or adverse effects. So as a health service, what we know you can do at the in-event health space is you can implement various strategies or interventions. And here's just a list of different types of things that you could do, which has been reported in various literature. And we're just in the process of finalising a literature review around this, looking at about 50 different festivals and events which have been reported as single case studies in the literature, and to try to make sense of the different interventions that people have implemented at those events, and therefore to try and see what things yield the best return of investment in terms of what interventions you should have to limit the impact on our health services and provide best care for people at events. So this is very broadly against the four domains of surge capacity, just as a way of putting them together in some meaningful way, the different types of things you might want to think about at events. And of course, you could drill down into these in a lot more detail, which we have. So what about the impact on external and community services? Well, if it's anything like Australia, you probably have ambulance services which are overwhelmed and emergency departments which are stretched on any given day. And if you were to walk into any of these departments, they would already tell you that they're operating at 100%. So if a disaster happens, or if they get an influx of patients from a festival or parade or concert or sporting event, it just adds additional burden to their services. We know that if you add additional burden to these services, there's an increased mortality and morbidity rates of those people who are trying to access those services, not just from the mass gathering themselves, but also from their local communities. So we did a literature review to try and better understand the impact of these events and on external health services such as ambulance and emergency departments. And in that, we looked again at the literature, and the literature is saturated to some degree with individual case studies. So another takeaway point for people interested in researching this space would be we need to move from the individual case study piece, and we need to start looking at bigger problems around mass gatherings. And by doing that, looking at multiple types of events rather than just single case studies. But here what we saw was that in those particular case studies, lots of people report on the patient presentation rate, the number of people per 1,000 that are presenting for in-event health services, so first aid type of services. As I mentioned, many places will have, or services will have, in-event health professionals, doctors, nurses, paramedics, allied health, and so on. And we wanted to try and understand what the role of those healthcare professionals was in terms of hospital avoidance. However, lots of the literature only mentions the fact that they either were there or they weren't there. Doesn't really describe the skill set and type of professional at the event, and it really doesn't describe the types of activities and interventions that they've been doing. Hence the literature review which we're doing at the moment around interventions at those events. So that's why it's normally a yes, no, are they there or not? The transport to hospital rate. So this is really if someone needs to be transported from the event via ambulance or other services to hospital, what that looks like. And this is variably reported in the literature. Sometimes it's reported as a rate. Sometimes it's reported as an individual raw number, which you then need to try and make sense of what that actually means. But often these are reported in the literature and give us a good sense about the ambulance service workload from a particular event. The other thing that we were really interested in was the referral to hospital rate. That is, how many people actually attend hospital, recognising that only about a third, depending on what country you're in, may come by ambulance, and the other 2/3 of people will turn up via their own private means or other ways. And it's really unclear and not reported very much at all in the literature about this particular impact. Anecdotally, though, we know that this impact exists. Because we see it as practitioners in the emergency department, patients presenting from events, but it's not very well reported. So we thought we should start to report more on this. And we've done a few series of papers now around trying to marry up the primary or patient presentations at the events with ambulance service provision, with hospital-based care needs to try and get a better sense of the impact of these events. So one of these events that we have here on the Gold Coast is a schoolies or a school leavers type of event where tens of thousands of people will present on the beaches and have a week-long festival. Traditionally, decades ago, there was no real established health services at this event, and as such, the emergency departments would be swarmed with patients presenting predominantly with uncomplicated acute alcohol intoxication. So it was established then, after there was noticing this increased workload, to have patients seen by a service at the beach itself here on the Gold Coast. And this schoolies type of event occurs in somewhat similar fashion in different jurisdictions around Australia. As a result of having an in-event health service at these events, there's dramatic decrease in the number of patients that present to our hospital emergency departments. And looking at another case now, this was one of the first studies we did where we tried to link the in-event health services to in-event doctors, nurse, paramedics, to ambulances, to hospitals. And here on the left-hand side of this are the outcomes related to the on-site healthcare professionals, and on the right related to the on-site first aid care. This was an event with about 20,000 people. It was a music festival on one day, started at midday, finished at midnight. So of those 20,000 people, you can see that 197 presented for on-site first aid type care. And the interesting thing over on the right-hand side around the on-site first aid care is the length of treatment. It's quite small, only takes about 11 minutes as a mean to see patients when they present for first aid type treatment. If they were deemed to require a higher level of care, they were then assessed by one of the doctors, nurses or paramedics on site. And then on the left-hand side, you can see what these are related to and a larger increase in the treatment time for these patients. So rather than putting everyone in the back of an ambulance and sending them to hospital, the idea of this was actually to monitor patients who are of low acuity at the venue itself, rather than transporting them to hospital. So as a result of this, of the 24 people who presented for doctor, nurse, paramedic assessment, 15 of them returned back to the event or returned home, 2 were discharged to police, and only 7 required transport to hospital. So instead of sending 24 people to hospital potentially, only resulted in 7 people needing to go to hospital. And you can see where they ended up on the bottom of that screen there. So for me, it's not about having an hospital avoidance strategy, because we can't always avoid people going to hospital. Instead, it's about minimizing hospitalization or hospital service usage or external service usage from these events by implementing different in-event health strategy. So there's a few challenges that I'm keen to talk about now as well, relating to major events. First one is crowd mood. Now, despite whatever interventions and strategies a health service might have in place at an event, one of those 3 core elements, biomedical, environmental, and psychosocial, is really hard for a health service to maintain or control. The psychosocial aspects of crowds, particularly around their crowd mood and motivation, is almost impossible for a health service to control. So you need to be working really closely with event organisers, other event services such as security and policing, to try and monitor crowd mood. Because we know if there's an increase in hostility around the crowd mood, there's going to be an increase in patient presentations. So here are just a couple of examples that you may have seen. These were on Netflix, some series about some major events that have occurred. And in these events, the crowd really started to take over the way in which the events operated, either by climbing over gates and just entering stadiums by themselves, or determining that the services that were being provided weren't of sufficient nature to what they were expecting in terms of experience, and therefore starting to riot and take over some of those services such as food and security and so forth. So if you haven't seen these Netflix series, have a look and see if they're still available. They give some good insights into crowd mood at major events. Another key challenge is around spontaneous events. So the events that I've spoken about so far are almost planned 12 or 18 months in advance. Even those grey ones which I spoke about at the communities where you live, they might be planned over a good 6 to 12 months. But spontaneous events can occur within a short period of time, hours to days, and quite get many authorities, policing, security, health, off guard. So here's some examples that I've put up here around civil unrest, riots, state funerals and protests, where we've seen increasing numbers of people being injured. And looking through some media reports recently globally about the number of people injured and deaths at these events, these can be hundreds to thousands of people who become injured related to spontaneous events. So how do you do health services at these events? Often the first line might be some tactical medical type of approach by the local government agencies, working together with security, police, military, or whatever the approach is in the jurisdiction where you live. But second to that, once people are removed who are injured or become unwell and are removed from that, it's almost taking on a disaster type of approach to how you manage patient flow, triaging people and removing them from the site to appropriate health services. So it's quite complicated. But in terms of thinking about them as a spontaneous type of event, it's normally the same key players that you might see in a planned event that end up at these spontaneous events. So I like to think of mass gatherings also as a place where we should be testing out our relationships with other agencies, where we should be using them as a test ground for what could we do if something bad happens and we need to escalate our level of care, and using them essentially as a bit of an exercise playground for disasters or spontaneous mass gathering types of events. So if you're a health service provider attending mass gatherings, consider how you might use some mass gatherings, starting even off with tabletop exercise or conversations with people, or introducing some real world scenarios to your events. Another one of the big challenges that we're starting to see emerge are climate-driven challenges. So here in Australia, we're prone to floods, fires and cyclones, particularly over the summer periods, which we're in now. The summer period also happens to be our high period for major events and festivals and so forth. So those two things end up colliding. This is an example here where there was a 3-day festival in Victoria, which is another state of Australia. And the event organisers had people arriving by car and camping out at the event. But a number of days before the event was to start, they ended up cancelling this event due to the bushfire risk or wildfire risk in the area. The upper image you can see is actually the bushfire or wildfire encroaching on some of the area in which that event was going to be hosted. And the event site did get impacted by fire during this event. So luckily they had made a decision to cancel the event and evacuate people before the fires approached. Challenges exist when that foresight isn't listened to and people want to progress with major events because they are an income generator. They serve a purpose in terms of bringing together people from a social and fabric of society perspective. So people like to attend events. However, as you can see here, disasters can easily occur if they're not cancelled at the right time. Here's the opposite. Rather than dry and fires, this was wet and muddy at a music festival again in Australia, where you can see by these event organisers continued on with the event and people ended up covered in mud and walking through mud. I think there's a need to balance participant experience, health outcomes, and commercial interest around events. And that's not always an easy balance to make. This is from Burning Man 2023 in America, where again, it got flooded. And on the bottom of the screen here, you can see 2, 4, 6, 8, 10, 12 lines of traffic trying to leave this particular event. That's a challenge if it becomes an isolated or remote event, whereby you don't have adequate services for a long period of time because you may have only planned the event to be a week long and you might end up isolated for 2 weeks. So in terms of the health service provision, it's important to take into account such factors as delayed removal from the event site itself and understand that you might actually be there longer than what you anticipate or be contracted to or whatever else that looks like. Challenges around people at events as well, and combining that with some of the spontaneous things that I've spoken about, where you might then end up with some civil unrest within the community in relation to this, or you might end up being people trying to leave a particular event and then being inhibited due to the fact that there are climate protesters or people blockading roads or whatever else it may be. So it becomes a really challenging situation. The other really extreme event which we're seeing, and we know this in general, is related to heat. So in most of the disasters globally, we know that heat impacts more people from a mortality and morbidity perspective than most of our other disasters combined. However, it's somewhat seen as a bit of a silent killer because it doesn't have that same sexy input that you might see in the media. The media likes to report on fires and floods and cyclones, but not necessarily on heat. Until we might see events such as this, which happened at the Hajj last year. These images are from the year prior to that, where nearly 1,000 people died related to the extreme heat at this particular event. Despite the strategies, which are reasonable strategies to put in place, a number of people still did die, unfortunately. The challenge with some events, and events such as this, is that you can't necessarily just change the date of these events. You can't just necessarily put them on we're not going to hold it during this period because it's too hot. If they're associated with religious calendars or other types of happenings within a community, that's just when you host those events. So it's important to come up with some strategies to limit the impacts of things such as heat in your events. From a responder perspective, obviously then, if you need to host an event during these periods, you need to have heat as a consideration in your plans, and you need to be talking with the event organisers about what heat strategies they might have at their events. And this is important from events with thousands of people right up to these types of massive events with millions of people. So disasters happen at events. This is not by any means an exhaustive list, but a short list of ones that you might want to have a look at on YouTube. The Bradford fire should be well known to many, where 56 people died, and essentially it started by what they think was a cigarette butt being dropped down the back of a stadium, where some rubbish under the stadium caught on fire. And this is a snapshot from the YouTube video after about 3 or 3.5 minutes of the fire starting. The Hillsborough crowd crush is another example of something to have a look at around how crowds move within stadiums. This was an event whereby it was a sellout final soccer or football match. However, some authorities allowed additional people to enter. Those people all congregated in the same area of the stadium, which resulted in a crowd crush where 96 people died and hundreds of people were injured. And here you can see images of people trying to get from the lower to the higher levels of the stadium, and also trying to climb over the barriers onto the field itself. So these are some lessons around event planning and how that may look. And in the Hajj 2015, there was a series of crowd crush events occurred, to which that led to a number of new strategies around Hajj, which have been successful in reducing crowd crush since then. Going back to disasters, of course, this is not an exhaustive list. We've seen many more disasters occurring at major events. So I'd encourage you to have a look at some of those. These are really good ways in which you can build lessons into your plans for events. However, as a provider at events, you're not normally staffing to respond to a disaster. You're staffing to respond to what would be a reasonable expectation of crowds and patient presentations on any given day, rather than what a disaster might look like. However, it's important then to have some coordination between yourself as an in-event health provider and the local health authorities, being ambulance or hospital emergency departments or departments of health, about what are you going to do if an event such as this occurs. Because, as I said, we've seen many disasters occur over the years, and it's likely that they will continue as well. These are just some other examples. And again, this unfortunately is a list which is becoming more exhaustive as well, whereby major events are seen as somewhat of a soft target for deliberate acts of harm, whereby hundreds of people may die at events due predominantly to the event infrastructure, the way in which it's set up, and the motivations of people as a single lone person predominantly at these particular events. So major events are a soft target for deliberate acts of harm. It's important that you understand that both from an in-event health provider perspective and also from a responding agency perspective. To move through large crowds of people provides a challenge. overall for mass gatherings. And that's why we end up with sicker patients at events and delayed access to people at events. It's predominantly to the access and the egress of emergency services being able to find people and access them at events. So these are just some examples of a short, becoming longer list of deliberate acts of harms at mass gatherings. So given all of these understandings of what it might look like normally, and now some of the key challenges around mass gatherings, what are some of the key things that you need to be thinking about as a way of providing adequate health services to people at the events, and also to ensure that you've got adequate community services to maintain their normal operations around events? I've mentioned briefly the built environment. We know that influences the way in which people move around events and how people can be accessed during the events. The event characteristics are spoken broadly around the different types of characteristics of events. That could be the type of event, the climate. We need to keep track on climate in relation to mass gatherings, given some really clear examples around the impacts of climate there. Got surveillance here. Surveillance is important. I haven't really mentioned the C word or COVID during this presentation, but we did learn a lot from that. And one is around probably local community surveillance. So having an understanding, even if it's the more generic type of public health diseases that we might see in communities, I'm thinking influenzas, gastro, and so forth, have an understanding of what the already community-based level of these illnesses are prior to a mass gathering might help you prepare. And it might be important too for in-event health providers to somehow provide surveillance from a syndromic perspective back to health services as well. The examples that I've given, particularly around the special circumstances of special considerations, is really about providing and having good communication with security and policing. Haven't spoken too much about the event to host population ratio, but this is essentially, again, if you have a city which normally has, I'll say, 50,000 people in it, or 100,000 people in a city, and then you bring an event which has 10 or 20,000 people attending at it, it can place a burden on your health services. If that city normally only has 1,000 people in it, and then you bring an event which has 10 to 20,000 people, it's going to overwhelm the health services of those towns. So there's a consideration around the event to host population ratio. Spoken about the in-event and external health services. Preparation is really important for these events. The longer lead-in you have and the more conversations you can have to balance the commercial need versus patient presentations and health need is really important. Just going to put the rest of these up for people to think about in terms of who you talk to and who you communicate with, how you get your messaging out. So if events are doing messaging around, hey, buy tickets from us, and this is where you need to turn up, this is how you're going to get transport to the event on the day. See if you can also do some public health messaging and communication during those other messaging aspects as well. So for really hot days, messaging around how to keep cool. For extended types of events, encouraging people to bring their own medication, ensuring that they've got communication and so forth with home about the safety and well-being of people with chronic illnesses and so on. So you might want to tailor your public health communications depending on what that's like for the event type. The in-event health skill mix, we know that just by having an in-event health service, that skill mix can really vary. Not every nurse is the same, not every doctor is the same. What skills they bring as a health professional to events is very different and can impact, therefore, the flow and effects to our external collaborations. Lessons learned, we often keep these quite close to ourselves, particularly from a commercial perspective, and not liking to share lots of information. However, share as much as you can because it builds a better understanding of our patient presentations and what that's going to be like. And it's to benefit the greater community rather than individual commercial interest. I'll stop there. Thank you very much for listening and for inviting me to give a presentation today. I now welcome any questions or comments from the team. Thanks, Darren.
Hey, Jamie. Thank you so much, Professor Ranse, for that riveting talk. I think there's already quite a number of questions posted in the chat. So we will start addressing them, and please feel free to post any comments, questions that you would like Professor to address in the Q&A tab, which we will be looking at now. So George's comment is, are you familiar with the collective club fire in Bucharest in 2015? It caused ripple effects and highlighted the corruption around the Romanian health services that were quickly overwhelmed by the need for major burns beds. Patients ended up in Austria. What is the major burns capacity in Australia? So probably we're not going to get into the politics of the comment, but if you could just speak about capacity and what you would advise health systems to do in a situation like that.
Yeah, perfect. These are really challenging. This is why it becomes challenging, because they are complex situations, because they do take into consideration political aspects, capacity of health services on a normal day anyway. What we don't expect to go wrong does go wrong. And we saw that in Taiwan with the Halloween crowd crush as well, which is another recent example. Burns disasters in itself, outside of mass gatherings, becomes challenging because there are normal capacities around burn bed availability. In Australia, we have designated burns hospitals. We see predominantly around our wildfires or bushfires the need to prepare those spaces for disasters. Unfortunately, in Australia, we haven't seen great use of those because people often will die or have minor injuries and illnesses related to fires. So we haven't really seen great overwhelm of our burns capacity in Australia. From a mass gathering perspective, which may result in a disaster, even Bradford City Fire is another example where there are fires. It's really hard. You're going to need to have good burns considerations and come back to really some basic principles that we know: cooling of burns, covering burns with something sterile if you can, and trying to get them to the best referral hospitals. I can't comment on other individual countries because I'm not familiar with health systems and so forth in those environments, but all I can say is that it's a challenge. If you've seen something occur in the past like this, we need to be documenting such things and building lessons that we've learnt from them. My mantra would be, if we've seen them in the past, we're going to see them again in the future. So you really need to consider those types of strategies. Yeah, unfortunately, I can't be more specific than that.
Yeah, no, I appreciate your insightful comments on that question and comment. My next question is from my favorite WADM person in the world, who says, my daughter is approaching 18 and has started attending mass gatherings such as concerts or planned events. I am concerned about her safety. Could you please share reliable resources or recommendations on how to stay safe during such events, including emergency preparedness and escape strategies? And perhaps comment on if that is something that you believe should be included in planned events and planned mass gathering events.
Yeah, so I think that absolutely a concern of anyone whose child's about to become an adult and wants to go to major events. And it depends, again, on the event type as to the type of risk that may occur at those events. A couple of key things. One would be, as an event organizer, to have some strategy and communications around people being safe at events. As an individual themselves, people will go out and test themselves at events, whether that be from just being in crowds, which they're not familiar with. It may be related to drugs and alcohol at particular events. So I would suggest a couple of key things. One is you need to have a communication strategy. That is how you keep in contact with your friends and how you keep in contact with someone at home to say that everything's okay and that we're safe. Another one would be, you mentioned evacuation stuff. So if it's an enclosed type of an event like a stadium, what we know about human behavior is that if something bad happens, most people try to exit the way that they entered a particular event. So encouraging people who are attending an event to also enter via one way, but be aware of where other evacuation points are. They're often utilised less than the main gates or main entrance points themselves. So as an individual, have a strategy about identifying other ways out if need be. Think of some key strategies if something bad does happen, and I'm thinking deliberate acts of harm and so forth. Strategies there, which are pushed here as a national perspective, are about escape if you can. If you can't escape, hide, and then tell someone what's going on via phone or someone at the event itself. So just having these, I guess, bits in your toolbox for people to take to events is really important. If you are going to go there for the purpose of alcohol and drugs, and you're not necessarily normally doing such things, people will experiment, but don't experiment too hard, and always have someone to keep an eye on you, or be the person that keeps an eye on other people, which was always my strategy when going to such festivals. I'd rather be the designated person to keep watch over people at events of my friends rather than get too ingrained in their culture of that. I think people need to go and experience major events. So softly encouraging people to attend is a good thing, I think, overall.
You may be in the minority in that regard, I suspect, Professor Ranse. I saw an interesting question in the chat. So just a reminder, if you can please post in the Q&A. And this is something that crossed my mind as well. You spoke about gathering data on expected attendees, but you also spoke about documentation within the events. So what is the important data? What would you prioritize in an event where the capacity may exceed the time
Yep.
that you have with, let's say, registration?
Yeah, perfect. So we've actually developed a minimum data set for mass gatherings, which starts off at really high level pieces. And it's just, you can simply start categorizing patients into 4 really broad groups, whether that be injuries, illnesses, psychosocial aspects, or environmental related patient presentations. This will just give you a sense about the types of patients that are presenting to those particular events. Underneath that, you can do another layer of, injuries. Well, what kinds of injuries? Are they just fractures, or is it sprains and strains or cuts and so forth? So you can get quite granular, but you don't need to be granular as a start. You can start off really broad to get an understanding of your events. That's also important from the syndromic perspective that I was talking about, because if you start to identify that there's a lot of people presenting with respiratory-like illness or gastro-like illness, particularly gastro-like illness at events, particularly if they've all eaten at a particular food venue or something like that, you can then start to put in place strategies to help limit other people becoming unwell. That's the first place to start, high level. It doesn't need to be really hard. And then combine that with other things if you want to look at multiple events. So going back to the environment stuff, like what was the minimum and maximum temperature or average temperature on that particular day, for example. We'll just give you some insights into the different types of characteristics which influence patient presentations. I think that's just important to do at the end of every event anyway, and share those really high level pieces with other people. There's nothing patient or personal necessarily in amongst that high level stuff. And it's also good to share that back with the event organisers themselves so that they know what's going on, and highlights the importance of event health providers at events, which sometimes event organisers don't really appreciate.
Mm-hmm. Yeah, so my next I'm combining two just to dovetail based on those comments. So it is, first of all, whether there is an established ratio of the number of healthcare teams or personnel that should ideally be deployed, and that's followed by does it depend on the type of event? And it really links to a comment in the chat that says if you do not have or cannot ask for the data, then how are you to determine health planning metrics? And I think those two go well together. If you can comment.
Yeah, perfect. Thank you very much. I'll go back to the very beginning of my presentation. It's not about the numbers. So some countries or jurisdictions around the world would say if you've got 10,000 people at an event, you need to have this many doctors, nurses, paramedics, first aiders, etc. Which is completely fine because you need somewhere to start, and provide a minimum standard is really important. But again, it's more complicated than that. It does vary based on the event and the environment and the crowd and so forth. So how do you know if you don't have an existing means? A lot of the previous planning for major events is historical in nature. And even today, people will do their planning based on the historical happenings of events prior. So going back and having a look at events which have occurred in your jurisdiction. So if you're, I don't know, going to be at a marathon, for example, and you've never been the health service provider at a marathon before, there are many examples globally around marathons. So start having a look at those to help inform you. Reach out to people within your own community or your own country, or even internationally. There's many people that are happy to help start in that process. But yeah, if you don't have an established set, it's got to be historical based. If you're starting from complete scratch and you don't even have any historical information or outset, you need to be talking to other people and the health services.
Agreed. And I just want to highlight our good friend Dr. Ali Hutton, who is actively on the chat, and thank you for being here today. And I will combine the next two questions if that's okay with you.
Yep.
The first one is it falls into health planning as well, but it is from Peter, who asks, how do you change agencies' perception to accept that all of health services need to be a part of the planning process? And I think that is something that most systems struggle with. And that is followed by Earl Hernandez, who is a major player in disaster management in Trinidad and Tobago, who is suggesting or asking if event holders should be a part of simulated tabletops. So should the event planners be a part of the health considerations to start off with?
Yeah, and I'll go back to this slide here, which highlights this really complicated considerations, but one of them is around interagency collaboration. So in the event planning stage, whoever's providing the in-event health service should most definitely be part of the interagency conversations around events. So often event organisers will be quick to have security and police around the table, but you need to find a place for health as well. So whenever they think security and police, we're also thinking health and well-being of people at the event. So it's difficult depending again on the established relationships, which sometimes can be no relationship at all to do that, but you need to find a seat around the table. Health needs to be in the plans. The perception is really difficult because often an event organizer might pay some money to someone to provide a health service at an event. And then every time they walk past that health service, they see people sitting around doing absolutely nothing, or what looks like nothing, because there's no patients there. So then they start to question, well, why would we have 10 health providers at this event? Maybe we only need 2. And then what they perceive to be the health needs is very different from what you know the health needs can be at any particular point in time. So again, I think that comes back to just documenting what types of patients you're seeing, how many you're seeing, even what time of the event you're seeing them. So at the end of it, you can provide some evidence back to the event organisers that there was a health need and what you've actually done. Now, just very briefly on that, I'm leaning more towards events also being health positive events. And by that, I mean, if you go to an event, often we wait for people to become unwell and sick and then we treat them. But imagine if you could go to an event and there was the opportunity for public health messaging, for sexual health screening, for other disease screening, opportunistic immunisations, whatever that might look like at a major event with a relatively healthy population of people. Might see a service provision quite different to what we see at the moment is normally operational response to something a bit more health proactive, and people come to an event and leave in a better health way than they did when they first arrived.
Right. I have an interesting question here that I'll throw out for your consideration. Rowena says that her workspace is in space health. And
oh yeah, hey Rowena.
yeah, and she often mentions the rise of commercial spaceflight and spaceports and the potential for mass casualty incidents and disasters, the need for emergency preparedness planning. So I think we all agree in the entire chat that preparedness is where we need to be in, where we need to focus on. But she's asking specifically, I'm wondering if you are aware of any work or publications in this area, and many thanks for the great talk today.
Thanks, Rowena. No, short answer is no, and I would normally come to you for such topics, but no, I'm not aware of anything as such. Highlighting though the preparedness stuff is important, but I'm also trying to emphasize, I guess, that the after action lesson learned stuff is equally as important, because that's what's going to feed into the next bit of preparedness for your next event as well. But Rowena, I'm not aware, unfortunately. Sorry.
Thank you so much. So can you translate that into not space, but airports? Because I think we've all faced long lines and massive crowds.
Yeah, sure. So I don't talk too much about some places which are just crowded places, right? Which are different from a planned mass gathering event, because these crowded places are an everyday activity. So they could be airports, shopping centres, particularly around Christmas time, it gets busy with lots of people. So that's quite a different type of a response to the mass gathering type of response, which I've been talking about. But those types of places, shopping centres and airports, will often have an escalation plan, particularly when they know that they are going to have an increased patronage. They will put on additional health services at those venues because they know they have more people there. So that's probably one example where numbers matter to some degree, because the rest of the characteristics are somewhat already defined, and there's less variability in the movement of, I don't know, the built infrastructure or the wellness of people at those events and so on.
Sure. We're running short on time, so I can just squeeze one more in, and I apologize to everyone for not being able to include all. We've generated quite a few. And this one is something that resonates with everyone on here who works with me. So she's Della is asking about spontaneous events, so like Red Bull events that thousands of people show up to, and just the basic question of how prepared can we really be to deal with things like that, political rallies where we see thousands of people gathering, etc. How prepared can you really be?
Yeah. So as you saw, one of my slides was about spontaneous events, because they are becoming more frequent and more challenging. They need to be a part. If you have a disaster plan for your health service, you should really have a section in there which is around these spontaneous types of events. I think that's where it best sits. It sits somewhere between the planned events and the unplanned events, like disasters, and in the middle of these spontaneous events. So I would encourage jurisdictions to really put them into a high risk element and high probability now these days within your health service disaster plans. I think that's the best place to put them. There's still some individual contextual pieces to it, depending on your jurisdiction, about who is the lead agency for such responses, how close to the red zone you might be allowed in terms of a health team. So yeah, that's where I would put it, and that requires consideration like any other part of your disaster plan, but have a specific thing there. All disaster plans, whilst they have a all hazards approach, I also encourage a top or high risk approach. It's like, well, in Australia, we know that bushfire, floods and cyclones. So why wouldn't we have sections on those? If your area is earthquakes or spontaneous mass gatherings, they should seek high up into your disaster plans as well. outside of your all hazards approach. You need a top hazards approach.
I really appreciate you. And I'm just looking through so many different comments and so many different questions, and I really apologize to all of those who I did not get to. Professor Ranse, on behalf of the LATAC chapter of WADM, I can't begin to put into words how much this means to all of us that you've taken the time to share with us today. Your expertise. I think everybody has benefited significantly from the time that you have spent with us, and I really look forward to more topics coming from your space into ours. To all of the participants today, thank you for your very interactive nature. We appreciate you all very much for again making the time. Thank you all very much. And of course, in the background, working very hard, people like Andrew and the support staff at WADM. The viewing audience may not be overly familiar with WADM, with Andrew, except through emails, but Andrew drives the success of this entire platform. And Andrew, thanks from all of us and from Amado, my co-chair, and Sandra, our mentor. We appreciate you all and thank you all very much for making the time today. We look forward to seeing you at the next webinar. And to those of you all who can make it to Japan for the conference, please bask in the educational opportunities. Thank you all and good evening.
Thank you.